In this lecture, we're going to discuss vesicoureteral reflux. So this is a very controversial conversation to be having. Several people feel passionately about vesicoureteral reflux one way or the other in terms of how important it is to both recognize it and to treat it. But I'm going to wade in there anyway. So vesicoureteral reflux is essentially a refluxing of urine out of the bladder and back up towards the kidney. Essentially, for reasons that are diverse, as a child tries to pee, the urine may come out a little bit, but much of it is going backwards, up the wrong way, and back into the kidney. There are 5 different types of vesicoureteral reflux, and we typically, historically, have graded them thus. We have grade 1 vesicoureteral reflux, where it's going just up into the ureter, grade 2, where it does the entirety of the ureter, grade 3, where we start seeing changes in the calyces in the urine collecting system of the kidney, type 4, where we're really starting to see significant renal damage, and grade 5, which is what we might call a megaureter, a huge ureter that goes up and back into the kidney. What's interesting about this is vesicoureteral reflux of all types may well completely resolve of its own in childhood. In fact, the majority of grades 1 and 2 will completely resolve on their own, about half of grades 3s, and then the minority of grades 4 and 5. But it is remarkable that roughly 1 in 8 patients with grade 5 megaureters will completely resolve on their own as they grow through childhood. So vesicoureteral reflux, when it's severe, and the reason why we're concerned about it, can cause renal scarring. This scarring will cause areas of the kidney that don't work correctly. And as you know, eventually if we keep running out of kidney, we end up in renal failure or with hypertension. So it's important to know how much renal scarring is going on in these children, as there is a theoretical concern they could end up much later in life with severe kidney disease. So for the last 20 years, we have understood a few things to be true. We have noted that children with reflux are more likely to get pyelonephritis. These children with reflux are more inclined to get kidney infections because they're inadequately emptying their bladder and because that potentially bacteriuric urine in the bladder is going backwards up to the kidneys. We also historically have said that recurrent pyelonephritis or recurrent kidney infections could cause worse scarring of the kidneys. And we have said that pyelonephritis-induced scarred kidneys could result in adult renal dysfunction. These are maybe sometimes true statements. However, what we've discovered in some studies is that when we look at adults with end-stage renal disease or bad glomerular filtration rates, virtually none of them have that as a result of recurrent childhood pyelonephritis. So that third point probably isn't true. The other thing we know is that while it's true that recurrent pyelonephritis causes scarring of the kidneys, it's not clear that it's the pyelonephritis that is at fault and not the vesicoureteral reflux that's causing pyelonephritis. Or perhaps it's some other underlying element of the kidney that's going on that causes it to scar easily. So these last 2 points are somewhat controversial, and we really can't say for sure what exactly is going on. But when we look at vesicoureteral reflux, it's nice to be able to decide whether this is a primary problem or a secondary problem. In other words, do they just have reflux, or is there another structural problem that we might be able to fix that's causing the reflux itself? Let me be clear. Primary vesicoureteral reflux looks like this. Here we have a normal bladder with 2 normal ureters coming into the bladder. And you can see the urine is flowing through a slightly angled area down into the bladder. The reason that tube slightly changes direction as it goes through that bladder wall is because when the child decides to pee and squeezes that bladder, the muscle action squeezing the bladder also kinks off those ureters. This prevents a natural backflow of urine and directs the urine instead out of the body. In a patient with primary vesicoureteral reflux, the problem is really that these tubes go straight in. They fail to angle slightly as the ureters travel through the bladder wall. As a result, when this child tries to bear down and have a micturition, the urine will also flow backwards up into the kidneys. This is usually unilateral, but it can be bilateral, or it could be bilateral with different grades, grade 1 on one side and grade 3 on the other, for example. Secondary vesicoureteral reflux happens as a result of a problem somewhere else in the tract. An example would be posterior urethral valves. That happens to boys, and we'll talk about it a little bit more on. Or ureteral pelvic junction obstruction. That's an obstruction higher up before the ureter even gets to the bladder. Patients may have a neurogenic bladder. We see this, for example, in spina bifida, where their bladder just isn't capable of constricting right, and as a result, urine can go backwards. We also sometimes see it in renal transplants when they have to physically put the ureter into the bladder.